Okay, so welcome back. I'm going to speak for a little bit on systematic reviews. We'll talk about what they are, why we do them, how you do them, and how you report them. So what is a systematic review? So previously, maybe you could get away with sending something to the journal which says, oh, this is what I think, and I've looked at a few papers, and isn't this brilliant, and this is the way it should be. But that's clearly a very potentially biased and random way of doing research. And this is effectively secondary research. This is taking some primary evidence, such as a randomized trial or multiple randomized trials, and trying to synthesize this into a secondary piece of work. So what do you need to do a systematic review? Well, you need a research question. It needs to be novel. There's no point doing a systematic review that someone has already done. And we'll talk a little bit about trying to work out who's done what before. It's critical, like with any study, but perhaps even more so with a review, to have a very well-defined and robust protocol. I've learnt the hard way, I think, that if you don't have a well-defined protocol to start with, you're just going to make more work for yourself. So, for example, if you've got a data extraction spreadsheet and it's got 10 fields on it, and you realise you've missed one once you've sort of looked at your 200 papers, you need to go back and look at those 200 papers again. So it's critical that protocol is there in full from the start, and that you try not to move from it. Also, similar to the randomised trials, it's important that you pre-register your protocol so that you can show transparency in what actually you're planning to do and what you have delivered. You need a research team. You can't really do this on your own because that does risk introducing selection bias. So it's important that you have a few members of the team, and it's critical that you have attention to detail. You're meticulous, and you make sure every last paper is accounted for. Let's turn that round and talk about narrative reviews. So this is sort of potentially a more traditional approach. A narrative review, it's not really a systematic look for the literature. You're maybe just picking out some of the articles that you remember having read in the journal, and really that's at your discretion, and it's prone to bias, inconsistency, and there's a lack of transparency there. And the real risk is that you get to the end and you've missed out the major trial that was published last year because you just don't really remember it. So those sorts of studies are very limited in the conclusions that can be drawn, and they're quite limited in their publication potential. So certainly at the journal, narrative reviews are not held in high regard. They might be as a commissioned piece, but generally they're not potentially very helpful. So what we've already seen this today. So why do we think that a systematic review is at the top of that pyramid, even if maybe Jonathan suggests it should be slightly at the side? Because it really assimilates the evidence below it, and because one study is unlikely to change your practice, one study on its own, because you never really know where it's come from and who was doing it and whether or not it's all been made up. Whereas if you've got a systematic review of 10 really quite homogeneous studies that are all saying the same message, then suddenly you're beginning to think, oh, actually there might be something going on here. This looks like it's quite good. We've got a picture here of Archie Cochrane. So Archie Cochrane was really the godfather, it's claimed, of evidence-based medicine, and is the founder of the Cochrane Review and the Cochrane database, and really is claimed to have bought medicine with it, from dogma and maybe just sort of anecdotal evidence to systematic, well-founded research and medical research. So we do it to answer a research question, and it's got to be novel and unanswered. We can look at either the published literature in terms of published reviews. So has someone already asked this question and answered this question? Or is maybe someone in the process of answering this question? And there is a register of systematic reviews that we'll mention later. And also systematic reviews are quite important at the start of any big medical piece of work, whether or not that be your dissertation for your MD or PhD, or a grant application. Because for a grant application, if the NIHR are going to give you £1 million to do a trial, you need to justify that someone hasn't answered that question already. So it's very important in both of those concepts. And we've already spoken about how to frame that research question. You need to know who you're doing, what you're doing it, what you could be doing, and what you're going to be looking at in terms of the outcomes. And as I've said, we need to be sure that we're not going to do all of this work for nothing, and we're not just replicating. So the BJS are not going to publish a systematic review on X if last week they published a systematic review on X. And that's sort of, it's far more likely to happen duplicating this sort of thing than it might be an original research study, a primary research. Because of course you can do this without patients, you can do this without ethical approval, you can sit in your office and do it, and for that reason it might be seen as an easy win, but I can hopefully convince you by the end this is not an easy win. It's a very satisfying thing, but it is quite hard work. So what do you need to get through this process? Well, you need a robust search strategy. And we'll talk about that in a few minutes. But you need to go from at least 2 sources. So we're talking here about the medical databases, be they Medline, PubMed, and lots of others, the Cochrane sort of database. You need at least 2 people to screen the abstracts because, again, you might have a view on something, but someone else might have a different view. So we're trying to, with more people involved, we're trying to reduce the chance that your personal opinion colours the amount of data or the evidence that you might be pulling out. You need 2 people to screen, and you need 2 people to extract the data and assess papers for potential bias. So we'll go through the stages one by one. The protocol is the most important thing. You then register, and the one I generally go to is Prospero, which is based out of the University of York, but there's several other international registers of systematic reviews. Now, the one thing I always look for as editor is when was it registered, because it's important to register this a priori, i.e. before you've done it. So if we have a submission in March and I look, I can go on to Prospero and see that it was registered last week. Now that's not the end of the absolute end of the world, but it suggests that the process isn't really quite as it should be, because it's about transparency. It's about saying this is what we're going to do and this is what we've done. If we haven't done this, maybe why not? So register it, do your search, and do your abstract screen. So you've got a search. You go into, let's say, Embase, and you put in your search titles, and you come up with 1,000 articles. Now, AI isn't perfect, and AI doesn't actually power Embase. It's just sort of term recognition. So you need to do the human check of that, a list of 1,000 papers, and actually say, 800 of these are rubbish, 200 of them have potential. So that's the screening of the abstracts, the titles, then the screening of the abstracts, and then actually the full paper search as well. So then you've selected all of your papers. Let's say you've selected now 15 papers that you think meet all of your inclusion criteria, and then you go through the process of looking at the evidence, extracting the relevant data, synthesizing it and reporting it. I'm going to go through some of these in a bit more detail. So in terms of our protocol, we need to be very clear what the research question is, what our search strategy is, and what our inclusion and exclusion criteria are. And we've got some of these listed here. So you might say, I don't really want to know about robotic surgery from the 1950s because that's completely unrelated to robotic surgery from the year 2000 onwards. So you could quite justifiably actually just exclude any data from sort of the millennium, I suppose. So you can make a very appropriate inclusion and exclusion criteria, but the important thing is that is defined before you run the search and is defined in your protocol. Study design, you might want to only do a systematic review of randomized trials, or you might actually say, well, there's not going to be a randomized trial. We're only going to do we're only going to do a review of retrospective studies. So it's important to make sure these are very clear in your protocol. You need to know who's going to do the screening and the paper selection and how they're going to do that. We'll talk about in a second the different ways. Either you can do it manually with an Excel spreadsheet that you email around, or there are some software programs available that make life, I think, a lot easier and a lot safer and a lot less stressful. In your protocol, you need to define how you're going to assess the quality of those studies, because your review is only going to be as strong as the weakest link. So if you've got 10 absolutely brilliant randomized trials, but then you've got one absolutely terrible randomized trial, the risk is that will pull all of your others down. So you need to talk about how you're going to assess for bias and actually how you're going to deal with bias. So will you exclude that paper? Will you do a sensitivity analysis? Will you just lump them all into one? And the relative merits and disadvantages of those approaches. And then meta-analysis, which I'm not going to talk about too much today, but effectively that's the quantitative data synthesis of your systematic review. Now, what I could have just said is stick to PRISMA. So PRISMA is preferred reporting items for systematic review and meta-analysis. So again, this is not about how to do a systematic review in the same way that CONSORT isn't about how to do a trial, but in reality, it's going to give you a lot of clues about how to run a decent systematic review and then how to report it thereafter. So in brief, I've spoken about Prospero as one of the registers of human research protocols, but there's several others, and the other one, sort of obvious one amongst there is Cochrane. So the Cochrane library, as I remember it, provides sort of systematic reviews of randomized trials of medical interventions. So your search strategy, and what I'd probably say at this point is find a librarian or find someone who's done a lot of these, because it's almost a different language. But it's critical because a weak search will lead to a weak paper. There are multiple scientific databases within surgery and medicine maybe as a whole. The most commonly sort of used ones would be Medline and Embase and Cochrane. So those are a good start. Get help from a librarian, get help from an experienced researcher. There is a different language, so terms such as EXP, which I think stands for explode, which takes not only the term that you've put in, but also all the subheadings underneath that term, and TIAB, which means that your database is going to search for your term in the title and the abstract, or you can just confine it to the title. And again, all of these things should be in your search strategy and in your protocol. So let's look at a search strategy from a relatively recently published paper in BJS. And this is just the first sort of 6 lines of their search strategy. So they're looking for any article to do with medical tourism and bariatrics. So this is just the medical tourism bit of their search strategy. So these are all the different terms that they've included. And what you can see on the last line number 6, is that they've basically said if any paper falls into any of these above lines, they're going to include it. I'll show you. I just sort of tried to replicate this in Ovid, and sorry, I've cut off the figures. The figures are effectively the same as what they've reported, a little bit more because I did it on April the 7th and they did it 2 years ago. But it's quite a good sanity check. And, if you want a bit of practice, go to the BJS, find someone's search terms and see if you can actually replicate what they've done. Because then you'll begin to learn the language of systematic reviews and how to use things like Embase to compare and search. So when you've got all of these results in Embase, I think that gave, I can't remember how many, 16, 17,000, you need to know what to do with them. And this is where you need to be thinking about working sort of smart, not hard, because this is what I used to do, which is I used to extract it into an Excel spreadsheet, and the risk is you'll lose papers. The risk is that there'll be hundreds of duplicates in there, and red was probably accept and yellow was chuck out. But I don't know why I was chucking out the yellows and why I was accepting the reds. But there is software, some of it open source, some of it paid for, that makes this a huge amount easier and more reliable, and safer. So. I've got no shares, but this is a screenshot of Covidence because that's what I've used, and it effectively, will take imports from Embase or PubMed, Web of Science, and then take you through that process, and will record why you've made the decisions, who's made the decisions, when they've made the decisions, and it will make the flow charts for you at the end of the day. So the one thing I always look at. Because I think it's an easy way to sort of see if someone's actually sort of on top of things as an editor is do. It's very easy just to add all these numbers up, and probably 50% of the time they don't add up. And okay, that's maybe a little bit pedantic, but at the end of the day, it might reflect something pretty serious in terms of the methodology. While we're looking at this flow chart, let's just look at the top of the screen. So studies from databases registers. Okay, so you've got 276 studies from Embase and Medline, and you've combined them all. So what are the other two? Well, the other two might be, or you've just heard about this really amazing study, or there's a really amazing study in the reference section of one of the other studies. I suppose the only note of caution there is, why isn't it in your search criteria? Why hasn't it actually come up with your search results? And you need to go back and maybe have an iterative approach to your search and say that actually you're going to change your search. So make sure all of those numbers add up, and they've got down to 5. So very manageable number of studies that they can look at in full. Of course, you need to then look at the full manuscript. I think most reviews would exclude abstract proceedings because you don't really get the full picture for an abstract. So you need to see the full text. Now, there are no full text in number 2. That's not ideal. You should think about sort of innovative ways to make sure you can get your papers. So email your friends. Go to the local university library, because one would hope that you could get sort of most of the full papers. 2 out of 5, not great, is it? Still got into BJS, so that's okay. And in terms of the outcomes, one thing I mention, if I don't mention it later, is that you can always email the authors about their outcomes as well. So if they've sort of reported on outcome X, but you want outcome Y, the likelihood is they can probably work it out for you. And it's much better doing that. And it shows that you've got a bit of sort of something to you if you can email the authors and try and get all of that information. As we've said, the results are always only as sort of strong as the weakest paper, the weakest link. So it's very important that we assess and we report the risk of bias in the papers that you're looking at. And there are, again, multiple tools. I keep going back to Cochrane. Cochrane has an excellent website. It's got a handbook on how to do a systematic review that I'd highly recommend looking at. And they've got multiple tools for risk of bias. Obviously, these are selected appropriately for the type of paper that you're looking at, be it a trial or a prognostic study. But In the whole, these bias tools are looking at whether or not that primary paper has selected patients appropriately, whether or not they've identified and adjusted for confounding, if it's a RCT, how they've randomized, how they've concealed, how they've dealt with the missing data that we've already heard about, how they've dealt with protocol deviations. And these really give us an idea, a flavour of whether or not this paper could and should be trusted. Because at the end of the day, if you've got 5 papers saying one thing, one paper saying the other, you really need to know whether or not actually maybe 5 of them are rubbish and then you've got one good paper which is the only true result, or the other way around. So data extraction, as I said, do it once. Do not sort of make up a new... sometimes it's not your fault. Sometimes it's your supervisor's fault, I would say. But do not realise that you've got to go and collect that. Sort of forgot to collect age or something. You've got to go and do it 200 times. And consider whether or not actually there's some software that would do this for you, because it's going to make your life, I think, a lot easier. This is a spreadsheet from some dark days that I had doing meta-analysis. So how are we going to put all of this data together? So there's effectively 2 main ways. One is qualitative. There's always the risk that you're going to say, like, I'm going to run a meta-analysis because I want to see that shiny p-value of 0.049999. But sort of a narrative qualitative approach actually might be far more valuable. And bring far more strength of conclusion than just sort of being obsessed about doing a quantitative meta-analysis. So a written description of the results, your appraisal, your professional judgment of the results as they stand. And you can still tabulate things, but you're not putting those results together. And you can't always put those results together, because actually this is the real world and these are human studies, and not everyone adheres to the core outcome set. So you've got someone who's reporting median blood loss and someone who's reporting mean blood loss. Now there's ways to transform that data, but they're not sort of hugely accurate. So sometimes you just can't. If papers have got very disparate patients, interventions, comparators and outcomes, then it's probably not appropriate to do a meta-analysis. The software for meta-analysis, you can use R, you can use RevMen. I'm sure you can do it on SPSS as well, to allow you to develop those sort of funky forest plots that we'll see in a minute. Now, there are many statistical intricacies of meta-analysis that I cannot and I will not go into. The one that I think understand is the difference between random and fixed effects models. Now, in surgery, things are dirty, and I don't mean the patients or the bow, I mean the data. I mean that actually there's so much noise, there's so much biological human clinical noise that you're almost never going to have a fixed effects model in a meta-analysis, as I understand it. So I would always go with a sort of a random effects model which anticipates and accepts for some of that statistical noise. The I2 statistic provides some measure of heterogeneity. So again, this is how different are these results, and how different are, what would we be expecting? And if the I2 statistic is sky high, it suggests maybe you shouldn't have been trying to pigeonhole all of those quite different studies together. And then we talk about publication selection bias. We've already mentioned the likelihood that a positive surgical study is more likely to get published than a negative study, and can we actually demonstrate that within our meta-analysis? So this is a commonly seen forest plot. You can see there's 3 papers at the top, all with sort of different risk ratios. Now they contribute a different amount. They don't contribute 1/3 equally to the ultimately result. They contribute based on the size of their confidence intervals, and often there be at the size of their samples. And ultimately here we've got a risk ratio of 2.5 for which the confidence interval doesn't quite cross 1. So you could say that there's evidence of a difference for that intervention. So you've done your hard work, you've done your review and your meta-analysis. How do you report it? And this is where Prisma comes into its own, and it provides, the ultimate guide, the gold standard guide on how you report your systematic review. And I'm not sure if it's mandatory, but I would expect and support actually submitting this with your paper when you submit it to a journal, because it demonstrates that you are trying to stick to these fully established and accepted guidelines for systematic review. So in conclusion, systematic review with or without meta-analysis can provide the strongest evidence to answer a research question. And it's critical that you have a well-defined, rigorous protocol to start with. Consider the rules and remember the rules of two. So 2 data sources, at least, two people screening your abstracts, your full text, and extracting your data. Ensure your search strategy is strong, robust, makes sense, doesn't miss papers, because you certainly don't want to go back to the start. Be meticulous and don't cut any corners, because you'll certainly regret it at the end. So I hope that's of interest. Quite keen to take any questions from the floor. Oh. Matt.
Thanks. Thank you very much. Going back to one of your first points about being specific about your research question and not doing something that someone's done before, I guess in surgery, often you can have quite quickly evolving fields with new trials, especially things like weight loss intervention at the moment. At what point can you re-ask a question, and kind of how can you justify re-asking? Should you re-ask a question? Is it to do with time frame? Is it to do with number of studies, new things?
I suppose I'd argue it'd be to do with whether or not the newest trial says anything particularly different to what the systematic review has said, or if it's considered to be, the trial to end all trials, in which case maybe there's relevance to adding it in. But if it's smaller than all the studies that have been published already, and it says the same thing, I suspect you're probably not adding an awful lot, and it's probably going to be a waste of your time.
Thanks very much. So I guess from a student perspective, systematic reviews are often kind of proposed as student projects. And firstly, I guess, have you seen an increase in systematic review submissions recently? And secondly, in terms of initial projects, do you think a systematic review compared to the classic kind of single center retrospective cohort study develops different / potentially more useful and robust skills for people just starting out?
So I think we certainly saw an exponential increase during COVID of systematic reviews, because you couldn't really do anything else. You couldn't see patients, you couldn't recruit patients. So the fallback default was, let's go and do a systematic review. I'm not aware that there's been a significant increase recently, but I suspect out of all the types of research, systematic review is where AI could probably just rattle one off without much trouble. So whether or not we'll begin to see a lot more systematic reviews, I'm not sure. Martin, is there a trend? I'm not aware that there's a recent trend.
I think, yes, I probably do see more systematic reviews than historically I used to. I think you've covered it well, but it really is a question of junk in, junk out. It is one of those phenomenon that, there's only really a point in doing a systematic review if there's a good evidence base from which to do it. You sometimes get papers in that have systematically reviewed a field and then found there's only 2 papers that were worth reviewing, and then they put that together, and that is unfortunate from the author's perspective, because I'm sure they put a lot of time and effort into it. But from a journal's perspective, if there's not a lot of material out there to synthesize, well, it's not really going to add much to our understanding, in all honesty.
If you were doing that for your grant application, that would be quite a good result, though, wouldn't it? Because it would tell you that you should be given the grant because the data isn't there or the evidence isn't there.
Yeah, absolutely. I mean, to answer your question about what you should do as a student, I think both have strengths, is the honest answer. what are you going to likely to get most out of it? It depends what your goal is. If your goal is to publish in a sort of top impact factor type journal, I suspect you're more likely to do that with a well done systematic review of a novel question than you're going to do with a sort of retrospective case series. But they both teach a student or somebody learning how to do research different skills that I think both have validity.
Yeah, and I think from my experience, I think I cannot overemphasize, the skills of organisation and attention to detail that a systematic review will teach you, because there's sort of no hiding, from turning your Excel upside down or sort of losing 50 studies along the way. Those are great skills, if not learnt by sort of mistake, learnt by doing it right, maybe. But equally, yeah, you as a student, you're not going to run a multi-center randomized trial. So it's relatively unlikely you're going to sort of get a sort of a primary research project into a mid to higher tier impact factor, but you might well get a systematic review in. But one should lead to the other as well, because you probably shouldn't do a primary research project until you've checked that actually the data isn't there. And so the introduction to a BSc or an SSc or a PhD or an MD, should be a decent systematic review. If you're going to do it for your thesis, you might as well then do it for a journal as well. Amira.
Read a systematic review and think, well, if only they'd used better search terms, they could have gotten better results. So what are your recommendations on how to pick the right search terms or keywords, and how many would you recommend per review?
So the recommendation really is to go and speak to a medical librarian. And in terms of the search terms, I suppose the more the better. But you can also look at previously published systematic reviews in high impact journals. So for example, if I want to do something to do with rectal cancer, there's probably going to be 10 terms relevant to rectal cancer, and I can relatively easily go to look at 3 or 4 articles and find out what those would be. But maybe if it's something that's a bit sort of more novel or a bit sort of sideways thinking, you might need to get some advice. But you certainly don't want to be in a position where you're looking back thinking, I wish I'd added that term. You need to stick them all in at the start and play around. Maybe just sort of test the system and that trial that was published last year, is that got into your results? Yes.
I have a comment. Pancreatic surgeons from Heidelberg, they came up with the idea of designing a living systematic review. So they would perform a systematic review and then collect all the RCTs and put it on in an app that you can download, and you can see all the RCTs that were published so far on this topic, and they are updating it every 3 months. And I think we should have platforms for this, apart from the traditional publishing, maybe also with good journals like BJS that would encourage such endeavors, because this way you get the recent data included. You then don't get a systematic review that was published 2 years ago. You get really real-time data.
Yeah, that sounds excellent. So it's never out of date. I suppose a list of papers is different to the actual synthesis of the data. I suppose what would be amazing if you could have a real-time program providing a meta-analysis, which probably isn't that difficult with today's computing, looking at Jonathan. But yeah, one would expect that to be possible. But yeah, it's a good idea to make sure that we're never out of date. Thank you. Yeah, Joe.
Yep. Sometimes when reading systematic reviews, you get a notion or a thought perhaps published in less impact journals that is there a surgeon as an author here, or was the aim only to publish a systematic review? You mentioned that the qualitative result section could be the most important, not the meta-analysis by itself. Should there be a demand for systematic reviews, or at least a risk of bias assessment that there wasn't an expert in this type of surgery included in the review?
Okay, yeah. So you want to have sort of agnostic sort of review performed by someone who's got complete clinical equipoise, maybe because they don't. The risk is they don't understand the field, and there's always a balance, isn't there, between, you need a bit of understanding to be able to interpret a result, but maybe not so much that you've already made your mind up.
True.
I think if you feel that's the notion, then you've got the ability to go back to the primary evidence and make your own mind up. But yeah, the narrative, sort of the qualitative synthesis can also always be biased. One would hope that in the meta-analysis, if a predefined at the start on a registered protocol, it's probably a bit harder to sort of slant that. But there's always ways to sort of tear statistics one way or the other to suit your argument. Okay, so let's ask Jonathan to come and give his views.
So some comments from a statistical consultant for the BJS. It's already been picked up, but I do also focus on the numbers that go in the Prisma flow diagrams, and it is often the case that the numbers don't add up. Or what I think is also true is a lot of people come who have a little bit of knowledge and expect a study to be there, and then if it's not there, you really need to know why, if this review is going to be useful. Those sort of studies that someone might anticipate would be in a review need to be covered, and if they are excluded, it needs to be justified why they were excluded, what is the basis, and why is this review not quite the review maybe you thought it was when you read the title. I'd also emphasize, think about which outcomes would inform practice and which outcomes has the review done. Reviews much more so than RCTs, much more than the typical cohort. Observational studies have a narrow set of outcomes, which is not necessarily a bad thing because it can help us focus what are the most important things, but they can often be a subset of those that are really important. And therefore, the review then isn't capturing all the key information. It's not that the review isn't useful, but that needs to be a caveat that's recognised about the study. And so we want to line that up with what would alter surgical practice. And then also, as a statistical editor, I'm interested in what specific methods are being used. So the package tells me some things. It doesn't tell me exactly what method we choose. And particularly if you use a more generic statistical package like R, SPSS, or Stata, or something like that, in principle, you could do anything you like, including quite crazy, inappropriate things. So just saying I've done a meta-analysis and I used R is not enough. Even with RevMan, it doesn't necessarily tell me you've done it the right way or exactly what you've done, and that does help people interpret the findings. So do be clear about what you did, how you pooled, as the language is often used, pooled the results of the studies together, because there's different ways to weight the studies. And then lastly, once you've done it, do reflect on the average or the pool that you've done if you've done a meta-analysis. Is it a reliable estimate? If you've got two studies that are polar opposites, the midpoint may or may not be useful at all. Probably not. More important is the fact that you got polar opposites of the results of those two studies. So what could be causing that? Is it bad studies, or is it quite different populations? Also, size of studies doesn't necessarily mean you have a very comprehensive answer. You could have 50 studies that have very narrow inclusion criteria, very precise estimate for a very narrow subpopulation. So do think about it when you interpret the findings.